And what I do is get on the table with them, take the arm, and just go real loose for me. Because the diagnosis in a lot of throwers is instability. I don't know how accurate that is, but that's what we usually think about. Just go real loose for me. Just drop your arm down. Perfect. So now I've got his arm completely relaxed. I'm using the weight of his arm to seat the humeral head in the glenoid and load the joint, and then do an anterior, inferior, posterior shift, and inferior shift. So I'm testing all of the ligaments and getting a feel for what's his normal anatomy. And this is what I do in the operating room before I do a stabilization procedure, because I want to make one shoulder as similar to the other as I can, allowing for activity differences. So that's his stability on this side. So let me bring you up this way and lie on your right side, if you would. And now go bring your right shoulder back towards me. There you go, perfect. Okay, and let me take this arm. Okay, so now I've got the weight of his arm, and it's hard to get somebody to trust you with this. But he's got no laxity, going anteriorly, inferiorly, straight inferior, or posteriorly. And as I'm doing that, I'm feeling for clicks and grinds, because that's where I try in the operating room before I put a scope in somebody to identify exactly where the pathology is. And actually, I'll say it in the operating room so that I can say, yeah, that's what I thought. But he has, there's no increased laxity in him. So I think, come on, sit up. So my diagnosis in Nathan, the diagnosis that I would put on the chart is scapular dyskinesis with secondary itises. I've not done the, I can't do it to you, all the stressful things, the impingement signs, because his impingement signs should be positive. You would think, because his scapula is not moving properly. Can you handle a little more? Yeah. Okay, slide over towards me.
Ben, in this kind of patient, what do you think about suprascapular nerve entrapment? Do you see that, is there any atrophy of the infraspinatus fossa in this patient? Can we check?
I didn't see any. Did you see?
No, I don't know. I just wanted to show. Can you stand up, please? I think that is pretty normal. You agree?
Yeah, I didn't. Perfect. Come and slide towards me a little bit. So the impingement signs, my exam that I do in the seated position is I just try to choreograph the exam to make myself more efficient. So when I have the patient sitting, and he is sitting in the typical posture of the teenage athletes that I see. The head and neck forward, the rounded shoulders, the thoracic kyphosis, the gut in, and that's something that what I'll usually do is that. And they look better, and they feel better too. But the steps that I'll do is I work across the body. So I'll do cross-body adduction to see do they have AC joint pain or posterior pain. When I have them here, and just tell me if anything hurts, okay? And then I'll do Terry Whipple's test with push up on my hand. That's his anterior supraspinatus. That's painful. And now let's see if we can change that. So this is the way Ben Kibler does his scapular retraction test. I have him do it actively, and if it's not working, I'll try it passively. Just relax your arm. Let me put you here. And Ben does this not for the Whipple test, but for the other part of the rotator cuff. But I'll hold his arm here, hold your arm right where it is, and push up. Okay, so his symptom was a positive Whipple test. The scapular retraction test corrects that. So I know that I can eliminate a lot of his symptoms by getting him to learn how to hold his scapula back in position. So I'll go from there. From here, I'll do Hawkins maneuver. Is that painful? Yeah. Okay, and that's painful. So he's got more sign of impingement. Come out to here and do O'Brien's slap test, thumb down, and push up. Pain. Okay, so if part one of the O'Brien's test is negative, I don't have to do it palm up, which is a sign of an AC joint problem. And then I'll come to here and have it push forward. Okay, so his impingement sign, his Job impingement sign is positive. He just told me he can't do it, so I'm not going to put him through that. What I'll do if I'm thinking about cuff and feeling for bursal crepitus or a rotator cuff tear is have them put their arm in the 90-90 position. And Nathan, if you would just rotate your arm like you're throwing. Okay, so he's got pain. I don't feel any crepitus there. And we know he's got some weakness of his rotator cuff. If I think there's biceps involvement, I'll do biceps provocation, first an abduction, and if it's positive, then I may go to forward flexion. If it's not positive, then I usually won't, then that speeds test. So push up. Pain? Okay. And now we'll wind up his biceps a little bit, and now push up. Is that body? No, I just can't do it. Okay. So I think the diagnosis that he would carry in most offices is either impingement, rotator cuff tendonitis, or biceps tendonitis, subacromial bursitis. I think that all the itis is. And if you're thinking of an itis in a young, healthy, active patient, it's their scapula. It's either the scapula or it's glenohumeral instability. Okay.
You have the floor mic? We've got a couple floor mics here, and I would ask you, if you have a question for Ben, that you ask it in the mic, because this is all being recorded. Does anybody have a question for Dr. Rubin on the exam? Dr. Esch told me to ask this question for him.
This is trouble.
Yeah, this is trouble. It's coming through Dr. Esch. Now, you're talking to the patient and the dad, and you say, okay, you've identified what you think is the problem. How long is it going to take your skilled therapist to get him back so he can throw again, if they're successful?
Within 3 months.
So you'd say 3 months if it works.
Yeah.
Okay.
The one thing that I didn't show was his pec minor test. And unfortunately, that's what happens is I'm talking as I'm doing it. I forget my order. So let me have you lie down this way on your back, and let's see what his pec minor is like. Slide up this way for me. Down a little bit, see. Okay. And if you want to be a purist about it, you should have towels under their elbows, because otherwise everybody looks like they've got pec minor tightness. But if I look at him from here, his left scapula is up. There's no doubt about it. So you'll see what happens when I push down on his arm here, and then I'll flip him to show the other side. On this side, when I push his scapula down, there's not really a lot of action with his arm. On this side, I don't know if you can, let me, Nathan, come up with your head up this way, please. So you saw how little movement there was on the right, but his left shoulder is up higher off the table. And if I push down, it's up. And the area that somebody like Nathan would be tender, come on and sit up for me for a moment, is right at the pec minor insertion. And I always do my palpation last. Pec minor insertion on the coracoid, right here on the right. That's okay. And I really didn't press harder on the left than the right. But that's where they have their pain, his pec minor. So you know that's the deal. So what we can do is, when I have him in the office with his folks, I'll roll up a towel that we have under the exam tables, put that between his scapulae, and then have him do that. And we don't have that here, but it feels good to do that. And it's a stretch you can really get them to buy into pretty quickly. So what I hope in my exam is that I can get them to buy into my diagnosis by showing them that I can eliminate a lot of their symptoms by making corrective maneuvers in the office. And then say to them, if you can hold these corrections, you should be able to get rid of your pain. And an athlete, that just stimulates them to do it, so that when I get them to the therapist, they're already sort of teed up for them.
We have a question?
Everybody seems to have a different definition for certain tests, like Speed's test, O'Brien's test. You know, myself, I do O'Brien's, I have them hold like that, and my Speed's is like that, but you did your O'Brien's like this, and you said Whipple's was my O'Brien, so I'm just curious what your definition of these certain tests are.
O'Brien's test in the article, what he defines as a positive slap test is you put the arm in 20 degrees of adduction and internally rotate, and if the patient on resistance of elevation has a pop or pain that is decreased by putting the hand into external rotation and supination, that's a positive slap test. That's a positive O'Brien's. If they have more pain in this position,